Hello and welcome back to my channel. If this is your first time here, I'm Nurse Alyssa, and today we are going to be doing a Wound Care Wednesday. So today we are talking about best practice standards, okay? Sometimes they can be very kind of overwhelming and a lot to read through, so I thought I would make them a lot simpler and easy to understand. So we are talking about pressure injuries today, so the prevention and management of pressure injuries. But first, if you could hit that subscribe button, it would be greatly appreciated, as it truly does help my channel reach more people. So let's get started, guys. So I know as I was starting out as a young nurse, the first time I got an order from a doctor for best practice standard for the wound, and I sat there and I was like, okay, what's best practice? I was actually unsure of this because it's not something that you learn as a nurse in school. You learn how to follow the doctor's orders and you learn how to actually put on the dressing. So when a doctor, and especially where I'm located, I receive these orders a lot, and it really got me thinking. And as I've been thinking back to my earlier days as a nurse, that hey, if I could make some videos to help out new nurses, that is what I am trying to do. So every best practice starts out with this circle of care, as you can see here. Number 1, assess and or reassess. Number 2, set goals. Number 3, assemble a team. 4, establish and implement plan of care. 5, evaluate the outcome. And if you have not reached your goals by number 5, you start back at number 1 and reassess. So let's start with step 1. You need to select a valid assessment tool. So there's many different assessment tools for pressure injuries, such as the Braden scale, and this is for risk assessment. There's also nutritional screening, pain assessment, and quality of life. Next, we're going to look at any causative factors, okay? What could be causing pressure injuries? What could cause a pressure injury? So we're going to start with the patient. So we're going to look at physical, emotional, and lifestyle. So the physical assessment, clinicians must evaluate patients' posture, activities, mobility, lifestyle, and current support surfaces, such as their bed and chair, to identify any potential causes of pressure and shearing. Pressure is considered the primary factor in formation of a pressure injury, and the internal pressure near bony areas can be 3 to 5 times higher. The addition of shear force doubles the impact of pressure. So we want to make sure that we're assessing while they sleep and where they sit, and any transfers they may be doing. Next, we'll look at the emotional aspect. So pressure injuries do have a negative effect on quality of life. We need to do a quality of life assessment to see how the pressure injury is affecting the patient and their family. This is going to help us understand their goals and how motivated they are to participate in their plan of care. If a pressure injury can heal, it's really important the person with the injury and their caregivers are committed to achieve successful results. This assessment is also going to guide the plan of care. And then we're going to have a look at the person's lifestyle. So the choices a person makes in their lifestyle is very important when it comes to preventing and managing pressure injury. Different factors like their habits, routines, health practices can all contribute to the risk of developing a pressure ulcer. So that's why it's really important to consider these lifestyle factors when assessing someone's risk for pressure injury. We also want to look at any comorbidities, disabilities, and mobile impairment. We are then going to complete a wound assessment. So a comprehensive head-to-toe skin assessment is to be carried out on all admissions and daily for those identified as a risk for skin breakdown. Particular attention should be paid to vulnerable areas, especially over bony prominence. So we've had our whole assessment, and now we need to set our goals. So the goals obviously our goal is always prevention. But if we do have a wound, is it healable, non-healable? So we're really going to base our goals on what we're trying to do, either prevention, are we going to heal the wound? Is it healable? So we need to base our goals on that. So unfortunately, not all wounds are healable, especially if there's not proper blood flow to an area, if somebody is in stages of end of life. It's just not realistic for these wounds to heal. So we need to be realistic with our main goals. And sometimes that's just reducing pain, managing smell, and controlling the fluid that's coming out of the wound. Next, we need to assemble our team. So that's step 3. So pressure injuries are caused by a variety of factors and require a team approach to address them effectively. Each team member has their own expertise, but also needs the basic understanding of pressure injuries, with the exception of their patient and their family, which we need to educate them on the pressure injury. So we do always want to enlist the patient and their caregiver as a part of the team, okay? We need to make sure that they feel like they're part of the team, make sure that they are heard, make sure that they're involved in the plan of care, okay? Because lots of times this is really forgotten and will create this whole plan of care, but it doesn't suit their lifestyle. So we need to make sure that the patient and their family are in the plan of care and they're being heard. So we do need to provide the necessary resources and support to our family, giving them access to consults, team members, equipment, moisturizers, skin barriers, everything that they need to properly care for the pressure injury. Then we're going to do step 4, establish a plan of care. So we need to correct any causing factors. So really with pressure injuries, we have to go back to prevention. That's why I always say prevention over cure, because when you're trying to heal a wound, you have to go back to the preventative measures anyways. So we might as well just be doing them from day 1 to prevent it from happening and not have the pain and suffering of having a wound, because they can be quite painful. So it's really important that we're finding a balance between their physical, social, and psychological needs. So we'll start off with positioning. So positioning patients for prevention and management of pressure injuries can be challenging. So here are some tips for prevention and management. So we want to move positions every 2 to 4 hours while in bed, and weight shift every 15 minutes while sitting. So it doesn't have to be a big shift in weight, just a simple shift from one side to the other side. That's really all that's needed. We need to avoid positioning the person with pressure injury on bony prominences. And we also don't want to be putting weight on existing pressure injuries. We want to limit the head of the bed elevation, use pillows or wedges to assist proper positioning, develop a sitting schedule, okay, where we're using tilt or recline, have an occupational therapist or physical therapist come in to help with transfer techniques to minimize shearing. We want to make sure that the patient and their family are aware of this position schedule so that they can follow it. Also check for slings. So if somebody needs a lift to get out of bed, some slings are meant to stay under them and some are not. So we want to make sure if the sling does need to be removed, that we are removing it. And then we're going to look at managing moisture of the skin. So dry skin is a significant risk factor for pressure injury development. We want to use a fragrance-free, alcohol-free moisturizer to hydrate the skin. We want to be cautious with moisture-associated skin damage. So this is inflammation and erosion associated with skin exposure to mucus, saliva, wet, urine, stool, wound drainage. We want to be aware of any fecal or urinary incontinence, or even heavy wound exudate. It can all cause skin breakdown. Then we're going to look at the actual wound. So we're going to optimize the local wound environment. So first we start off with cleaning the wound. So we're going to use solutions with low tissue toxicity, such as saline, sterile water, acetic acid. We're not going to irrigate if you can't see where the solution is going or it cannot be retrieved or aspirated. Antimicrobials are great for infected wounds if there is a local infection, but I suggest leave that for only locally infected wounds. We want to just use something like sterile saline if there is no infection of the wound. Then we're going to look at debriding. So there is different debridement methods, and it just is based off of the patient, the wound, the environment, scope of practice of the person conducting the debridement. So you can use any of the debridement methods depending on what you have been trained for. So autolytic, mechanical, enzymatic, biological, sharp surgical. Now, if we have dry, stable eschar on ischemic limbs, we are not going to debride this. We are going to leave it. And for non-healable wounds, we're only using conservative debridement. We need to look at bacterial balance. So it is absolutely essential for wound healing. Failure of a wound to progress towards healing is a good indicator of potential wound infection. And then we have moisture balance. So we do want to keep a wound just as moist as our eyeball. And we do this through the different dressings. So some do add moisture, some wick away moisture. So just being aware of what type of wound you have, what type of exudate, and using the appropriate cover dress. And we want to just make sure that we are consistent about implementing the plan of care through all of our team members, our patient, their family, that we are following a schedule and we're sticking to that plan of care. That's why we want to make sure that the patient and their family is involved in creating the plan of care so that they are willing to move forward and implement this, because for the most part, especially in the home care setting that I am used to, we rely on the patient and their families quite frequently to do dressing changes, with nurses just coming once or twice a week to check on the wound, making sure it's progressing and not getting worse. We really do rely on the family member. And then lastly, step 5, evaluating the outcome. So have the goals been met? Were we able to prevent the pressure injury, or do we have progression towards healing? If the goals have not been met or they've been partially met, it's important that we once again reassess and go through the 5 steps once again. And there is a possibility of needing a wound culture. Now, that's if we have signs of infections. It's not recommended that we do a culture if there are no signs of infection, but use your Nerds and Stonies. If you're unsure of what that is, I'll link it down below. So if you are suspecting infection, then we can do a wound culture, because that could be preventing the wound from healing. So we want to ensure sustainability. We want to support prevention to reduce the risk of reoccurrence. So whether or not we've met our goals, we want to prevent any other pressure injuries from starting, or if they have healed, we want to prevent them from reoccurring, because that tissue, once it is open, you are so much more susceptible of it reopening, because the tissue actually takes a full year to go back to normal. So the whole wound process, even after closure, it takes about 1 year to have full closure, full healing of that wound. So that's why the reoccurrence rate is so high with pressure injury. So I hope you did find this helpful. Now, if you are looking to print this out, I'll have it linked down below, the PDF, where you can print this out. Once again, I hope you did find it helpful, and I hope to catch you in my next video. Bye for now.